here for you. And we're so pleased that Liz McCarthy, who's the Regional Director for Healthcare Systems for the National Office of the Alzheimer's Association, is here to facilitate. She will introduce our panel. You will have a chance to ask questions. And what we're really exploring is more of what Dr. Cabral shared with us of what care looks like in Vermont and what can we imagine for it to look like. So thank you, Liz.
Oh, sure. Thank you. It looks like there are still a lot of people who are not in the room. But I will say that this, when I was sitting over here listening to Dr. Cabral, and it looked to me like church, or so everybody is in the back and in the corners, and the panel, we don't have slides. It's going to be Q&A. So if you wanted to move into the center so you can hear better, you can do that now. And of course, no one did that. So not to delay too much longer while people are coming in, I will introduce our panel. I'm going to start from my left on the far, where am I? Yes. On your far left is Dr. Richard Orland. We're so happy he's here. He is the lead physician for the Community Health Center in Rutland. Did I get that right? So?
For the geriatric service line.
For the lead physician for the geriatric service line. And I just discovered that he has to travel to Rutland from Putney, was it? So, yeah. Yeah, okay. I'm getting things half right so far. I'm failing as a moderator, but would you like to introduce yourself, sir? Okay. Next to him, we have Kristen Bolton, the Executive Director of Elderly Services in Middlebury, Vermont. Did I get that right? How did I do that?
Doing perfect.
Okay. If I botch Christina Haygood, who is the nurse practitioner at the University of Vermont Medical Center Memory Center, because I've been on like 40 meetings with her in the last
You
month.
got the last name correct. Thank you.
Okay. How about the rest of it?
Yes, nurse practitioner in the memory program, UVM Health Center.
Okay, perfect. Brenda and I have also been on maybe not 40 Zooms, but several Zooms with Brendan. Brendan is also a nurse practitioner and is the principal for Full Circle Medicine, a primary care practice that does primary care at home, based in Heinsberg.
You got it.
Okay, all right. I don't know if I can say much more about Dr. Danny Cabral. So, love that you spent some time in New England, though, that you're not just Southwest. So,
I grew up in Massachusetts.
Oh, you did?
I know, I didn't mention it. I should have.
Yeah, where?
Webster.
Webster. All right.
Yeah.
That's in Central Mass. I'm also from there. Sorry. I just so that the car that you see with the Mass plates out there, it's mine. So don't be mean. And then Mark. I'm sorry, Mark. How are you?
How am I?
How are you?
Thanks.
Excellent. Mark is the Executive Director for Senior Solutions Council on Aging, covering Southeastern Vermont. How'd I do? Accurate?
Yes, that's Southeastern Vermont, Council on Aging, yes.
Okay, so one more pass. Anybody coming back in, you can sit towards the middle or towards the front. First, I'm going to ask a question of the entire panel, so it'll be the same two questions for each of you. And we'll start here with Dr. Orland on the end, go to the end, and then we'll give it to Mark and come back the other way. So Dr. Orland, if you could start, describe your role in the care of people living with dementia.
I can't remember. So first I have to say I'm not aging, I'm fermenting. So if there's a question. So I consider myself a born-again geriatrician. I actually am a biochemical pharmacologist who started in internal medicine, became a critical care-based nephrologist, and then woke up and realized that most of the people I was taking care of didn't know I was there, and they needed extra help and nobody else was caring about it. So I actually moved to Tampa Bay, got on board of the Alzheimer's Association down there
Thank you.
in the early 21st century. And I started doing geriatric care with for-profit, not-for-profit, faith-based, and different settings. So what I learned was no matter where you are, that you can take care of older people if you have a team, right? And that someone has to ask the question, what did you have for dinner last night? And if you can't remember that, that's a good start. I don't care, you don't have to have a diagnosis, but it's eventually going to be important if you want treatment. But you have to start the conversation, and you have to start it early, which is part of what we heard this morning. And what we're hoping to do with Rutland, and we continue to do, is to screen people early, and to listen to them and their families, so that when they present, they have a question or a problem, maybe we can be there to help.
Brilliant.
Does that help?
Yeah, thank you.
All right.
Thank you very much. So the same question to you, Kristen, and I can repeat it. Describe your role in the care of people living with cognitive impairment. What were your other terms, Danny, that you used? Did not say dementia?
I use cognitive functional impairment.
Okay, with cognitive functional impairment.
As the Director of Elderly Services, our primary program is an adult day program. Have you all heard of Adult Day? Yes. So I like to tell people it's like a school for older people, and it provides a community for people living with dementia as well as their caregivers. So we work with people who are in our center, and we give people who are their caregivers the guilty pleasure of being able to have time to themselves. And within our center, we provide a community approach. It's a mainstreamed community, so not everyone has cognitive functional impairment. Some people are lonely because they lost a spouse. Some people are lonely because they're 93 and all their friends have died. Some people have had strokes, so it's very much a very diverse community of people with various abilities and disabilities. And we provide a fun-filled day, joyful connection, spiritual connection, and the caregiver also gets to enjoy the benefits of this because their loved one is really happy when they leave. And so not only has the caregiver had time for themselves, but they have a happy person to help at home, so they've had a break. We're also a very affordable alternative to institutionalized setting and to one-on-one care. And so we had the benefit of that community setting, which prevents isolation and loneliness. And then we are affordable because it's a lot less expensive than paying $35 to $40 an hour for someone to come into the home and really still keep more of an isolated aspect. Some of the stigma you talk about, I feel like, can dissolve with participating in a community.
And do you want me to repeat the question, Christina?
I think I got it.
Okay,
Thank
awesome.
you. So I'm a nurse practitioner with the memory program. I was brought on through the BOLD grant about a year and a half ago to join the memory program as to implement the Vermont Alzheimer's and Dementia Care Program, which is based on the UCLA pilot or the UCLA ADC Alzheimer's Dementia Care Program. So this was a pilot, and it really is focused on working with the dyad, focusing on caregivers, connecting them with some support resources, and a lot of just meeting with caregivers and trying to be somebody who they can relate to and they can get advice from. So we wrapped that up. I'm now in a more permanent position with the memory program, thank goodness. And we're working with the VADC now to try to take some of the lessons that I learned from the pilot program and try to change the way things are done in Vermont.
My name is Brendan Conroy. I'm also a nurse practitioner. I opened a practice about a year and a half ago called Full Circle Medicine, providing in-home primary care to individuals, primarily folks living with dementia. Really with the reason for the practice was seeing this gap in care for people, especially with moderate to late stage dementia, who just getting out to a primary care office is such a challenge. especially if they are not feeling well. It's stressful for their caregivers and also just overwhelming. And also that traditional primary care visits lasting 15 or 20 minutes just do not work for somebody with a cognitive impairment. It really takes a lot more time to, be able to spend the time with them, maybe spend some one-on-one time out of the room with the caregiver, evaluating the home setup. And so that was sort of the impetus for the practice. And so it is primary care, but primary care specifically for folks living with dementia.
Thank you for all of what you all do. Wow, that's great. You already heard about me.
I'm Mark Boutwell. I'm the Executive Director of Senior Solutions, as you saw up there. It's the area agency on aging in southeastern Vermont. My role, well, I will speak for all the area agencies on aging. There are 5 area agencies on aging in Vermont, and the agencies on aging are stipulated under the Federal Older Americans Act. So each state gets funding and has a plan under the Older Americans Act, and Vermont administers that plan through independent, not-for-profit agencies on aging. So we cover 46 towns throughout southeastern Vermont, largely Windsor and Windham counties, but also Orange and Bennington counties. So under the Older Americans Act, we are actually stipulated to provide caregiver services, and there's funding attached to that. So we have to first of all, we have to provide those services, and we have to account for them. And second of all, of course, it's so important that we do that under the Older Americans Act. And we give priority, and when we think about the services we provide, we prioritize caregiver services and do things to reach out to caregivers so that they know where those services are available and who we are and how they can reach us. And again, one of the roles that we play through the state, through Dale, is that there's funding attached to these services. So we just heard about the adult day centers, and we administer funding stream that can support people attending adult day centers. And we also administer funding through the Older Americans Act that supports senior centers. So we have ways, both directly and indirectly, to support these services throughout the state. And again, pretty much anywhere you go in the state, you will be able to receive the same level and quality of services through the agencies on aging and the programs that we support.
Thank you, and so keep that microphone, Mark, because you're number 1 for the next question. What does dementia-capable care look like to you?
Dementia-capable care, it really, well, I think for me personally and the agency I run, which really speaks to a lot of your comments, and particularly if you know Vermont, you think about the Northeast Kingdom and also Windham County are extremely rural. So dementia-capable care means finding ways to reach out to caregivers and their loved ones in those rural areas. And it's a challenge. It's a challenge for people to get to services. And so again, we try to find ways to reach out to them. We have outreach workers, we have case managers, and so we have a number of ways we make services available to folks with dementia and cognitive decline. One of the things that I'm really excited about that Senior Solutions provides is we have 4 different sites in which we do memory cafes. And so These are monthly events where care partners and their loved ones can come together, and there are activities for the person living with cognitive decline, and there's also peer support for the care partners. And we've seen really a lot of success with that model. People, typically caregivers, rightly so, are reluctant to, even when they have respite, to leave their loved one at home. And if we can provide a setting in which they can come together and both have enriching activities or engagement, that's what we want to do. So that's one of the areas that we're really excited about. The other area throughout the state is an online caregiver platform called True Alta. And again, at any of the agencies on aging, it's something that we pay to subscribe to, and then we make it available to caregivers. And it's one of those platforms that you can go on 24/7 in the middle of the night if you're up and you need some tips on how to deal with sundowning or some other challenging issue. You can log into this platform and get some educational tips, whether they're 3 minutes long or half an hour long. So that's something that we're very excited about making available. Certainly we have respite funding and support that we provide. So people come to us and we can provide funding for them to purchase respite so they can get out of the house. Obviously information and referral, and the other service that we provide, again, throughout the state, there's something called options counseling. So families, care partners can come to us and get counseling about what their options are, what long-term care facilities are available, where they should turn for estate planning, things like that really support them in decision-making for themselves and their loved one. And then, of course, we do provide case management, and part of that certainly is helping people get connected or stay connected with their primary care physicians or make neurology appointments or things like that, so that they're getting the medical care that they need. So those are a few of the ways that we are practicing capable dementia care.
That's amazing. Thank you. So, Dr. Cabral.
I'm going to take it in a slightly different direction. I think about any environment or group of people or person that can see someone or a family who's facing one of these diseases and is compelled to look deeper at what's there or could be happening. And so from a positive perspective, I mean, so I have a 5-year-old and she has this book called Look Again, that, you open it and it's like a cat, but then you spread out the page and it's like this beautiful scenery with probably rainbows and unicorns. But I think that like all of us know that there's more there, but it's up to us, it's relational, to help bring that out for that person who used to do it for themselves. And I love, and I think of this kind of space where you don't know what you're walking into and you're fine with that. Like, I walk in a room and I'm like, could be 1980, could be 2000, could be 1960, I don't know, it doesn't matter. Like, what year is it? How old are you? What's going on? And you can flow with that and know that, like, being fixed and rigid isn't better. It's not better if we're in the actually 2025 for that person, and how to see and be open that something even more amazing could come out of it if you're present with that person. Sorry, that was like up there in the clouds, my answer.
Check out that book.
So when I think about it, I definitely agree with what's already been said. It's this very holistic approach. When I think specifically about our state and our region, and what, some areas that we could focus on, especially from a kind of a clinical perspective, is empowering primary care, really, to feel more comfortable caring for individuals, diagnosing individuals with dementia, supporting families, because the reality is the memory center is amazing, but they are limited in the number of people that they can take. And so often it falls to primary care to be the ones managing all of it. And it's a lot to manage. And so how do we support primary care? These individuals who are already so taxed and have such a limited ability to spend time with people, how do we support them as a state to, allow them to care for people with dementia and their loved ones? And also I look at, our hospital system and kind of all of the pieces and parts, because individuals with dementia have many touch points in the healthcare system. It's not just primary care. They're going up for an ultrasound, they're going to x-ray, they're in the ER, and how do we make sure that these people are supported in all of those areas? I had a patient go up for an ultrasound to rule out a DVT, a blood clot in her leg, the other day. The person performing the test did not know that she had dementia, so thought she was just sort of this agitated and, unwieldy person, and so became quite agitated back with her. This person didn't know, they did not know that she had dementia. The care partner did not know how to navigate this. And that's just, one scenario that happens a million times a day, right? Is these people are kind of thrust out into the medical world, and, the medical world doesn't always, A, know that they have a diagnosis of dementia, or B, know how to navigate that. And so how do we, collectively come up with a better system and a better way to make sure that people are knowing about somebody's diagnosis and also supporting them in all of the different ways that they navigate the healthcare system.
Dementia capable. So I think that, as Dr. Cabral mentioned in her wonderful presentation, there's a lot that goes into the barriers. What are the barriers that prevent us from really enforcing, developing dementia capable care? And I think that stigma is one of the most significant factors. I work with a lot of folks who are just incredible people, and once they receive their diagnosis of dementia, it really is this tragedy that happens to them. And I try to talk to them about all of the people that I work with who, you continue to live a wonderful life that's full of joy and full of meaning and full of connection. But there is still this underlying stigma. Also working with folks who are mourning, they're diagnosed with dementia and they're mourning the loss of their family structure as they knew it, which is contributing to mood symptoms, behavioral symptoms, because the grandkids don't know how to interact with them anymore. And so the grandkids are afraid and they're staying away. And so there's this loss of connection, and I think that connection is another big piece of dementia-capable care. And it's not just connecting care providers and systems, agencies on aging and providers, and all of the different systems that go into supporting dementia and the caregivers. It also goes into just the lack of connection that we have as a society, and how isolated a lot of folks are, and how much that leads to a delay in recognizing the symptoms, a delay in recognizing and getting a diagnosis and getting treatment and getting connection to the services. So it's a lot to do with really difficult challenges like reducing stigma as a society with aging, but also doing a better job of connecting professionals and connecting individuals within the community.
Thank you. Well, it's great to have all these perspectives. I'll share the perspective of someone who works with a wonderful team of people to care for about 125 people. About 75% of them are living with cognitive loss or dementia. And so I was thinking dementia-capable care is how do you work with the person who's right in front of you, who's wondering when her mom's going to pick her up. or in half an hour wondering where the kids are, and she's not talking about her adult daughter who's going to be there in half an hour. She's talking about her little kids. And so I feel that dementia-capable care is highly individualized. Every person experiences this differently. And it's very improvisational in the way that Dr. Herb Cabral talked about it. I really feel like I've been trained in improv some days. You just go with it. You're not going to tell the woman who's looking for her mother that she died 20 years ago. I think you all know that. But how do you help her get regulated? Because what she's really experiencing is this dysregulation, and it's very dysregulating to have dementia, even if you're more clear-minded. Why are things not making sense, and where am I? And so it's both an individualized approach, and building relationships for us is really how we address dementia. Medication, sure, you want to make sure the meds are on track. We have registered nurses. Social workers to help the family so that issues at home are more manageable, but day-to-day, moment-to-moment, how do you help this person become regulated? It's the relationship. You develop a deep and trusting relationship based on mutual respect. So you have to really love the person in front of you who's looking for her kids and is holding on to the teddy bear. I mean, not all of them are. Another man might be falling asleep, or he doesn't want to engage in anything. How do you help him be himself? We're kind of valuing the human spirit. How do we help people still be the person they are in spite of or with the changes that this disease brings to them? So that's what dementia-capable care looks like. And it doesn't just happen one-on-one. It happens in community. People helping each other, another person holding this woman's hand who's feeling a little fraught. And then they have a purpose. They can help other people. So there's a real richness to this that is where the joy is. It's not easy. I'm not saying it. It's not tragic, but there can be joy, and it's through the relationships and connections.
Wow, it's been many years since I've been a cleanup batter. So it's hard when you have the attention span of a flea to stay on focus, but I wanted to try to close this out with a couple of thoughts. One is, I wear many hats in my semi-retirement, you tell by the lack of hair of greatness, that as a hospice medical director, that the GUIDE program maybe will be similar to the Medicare hospice benefit in the sense that is more than just the medical care of the person who's going through the active part of dying. It's the family care, it's the support, it's the post-loss care that makes the hospice medical benefit work. Well, why can't the GUIDE program be that? And I'll circle back to that in 1 minute. So let me just give you the 411 on the community health centers of the Rutland region, because I don't know if everybody knows what we do. We're the largest provider of primary care services in Rutland County and its environs. We have multiple freestanding primary care centers that take care of people from literally the cradle to the grave. And we have specialty services that include dentistry, eye care. It's all funded through a federally qualified health center. It is a unique medical model. So what that allows us to do is to really get people through their aging continuum, through their medical traumas and stresses, and identify them. So how's that dementia capable? Find the triggers, see the triggers, identify when people are at risk, and then throw everything you got at them. And the beauty of our system is we have case managers. We have a team of case managers built into our primary care program. Where do you have that? We have a robust behavioral health component. So while mental health is obviously a very important problem when you have dual eligible and dual diagnosed people as your primary clients in many cases, we have a capability of really seeing people across the whole spectrum. It's wonderful. So another hat I wear. There's a company called Isaac Health. Have you heard of it?
Yes.
It's a web-based, one of the 40 GUIDE providers that's out there, and is taking care of people across the country with dementia and dementia-related disorders. As the medical provider that works with them, I'm doing their medical evaluations virtually. It is cool, all right? I'm pretty old, and I've been doing this a long time. I would never think that I could sit in front of somebody after they've had an adequate neuropsychological evaluation and a close to at least primary diagnosis, hopefully after the right imaging, which is right in-house. And I mean, I could sit in someone and feel comfortable saying, hey, we got to talk. There's some stuff that we may be able to do. There's some stuff we may not be able to do. And these are all the things in your community, if we get all that resource managed, that we're going to be able to do for you. So it's terra firma, but now it's also virtual. And this is the only way we're going to fix this problem. That's my circle back.
Hold on to that, because I'm going to come back to you. I'm going to ask each panel member now a question designed just for them. But thanks for all that. I thought that was really great, coming from each person's area of expertise. So, Dr. Orland, for you, the question is, describe what dementia care looks like in Rutland. How are assessments and diagnosis managed, and is there a defined clinical pathway?
I can't use bad words, right?
Well, so it's a challenge, right? Because how many neurologists are there in Rutland now? Zero. So it's literally, did someone buy something on Amazon? Is that
My groceries are being delivered.
Okay.
Yeah.
So, you know, and again, Rutland is it's a tough town. There's a lot of stuff that's going on. And without having someone to help you with movement disorders, with seizures, with, you know, everything else that goes along, how the heck are we going to take care of dementia? So it then falls on primary care providers to do the screening. Well, wouldn't it be nice if our annual Medicare wellness visits were being done? At least you'd have a screen. Well, I'm here to tell you, we need to work on that. So there's a lot of opportunities that then, therefore, are missed. So what are we doing, hopefully, in January? We're actually setting up a geriatric assessment program. And what we're going to do is get people identified in our primary care program, hopefully, people that are getting discharged out of the nursing home and can't get to their doctors quick enough and maybe they have a diagnosis, and other people at risk within our practice, and say, hey, let's see, can we get closer to a diagnosis? Can we set up their imaging? Can we get a metabolic study? Could we get infusion care? I mean, you know, subcutaneous infusion's unbelievable. The problem is the numbers are going to tell us whether this all makes sense or not. And as a biochemical pharmacologist, that's the other hat, I'm going to tell you, I'm still suspect of all this stuff. So you got, I'm from the Show Me State, Brooklyn. But, so dementia care in Rutland, we have opportunities.
Okay. Kristen,
I'm working on my, you know, my evening shtick too, so.
Kristen, what innovations has your day center developed to improve care or access for rural individuals living with dementia?
I think adult day is still an innovation. So it's underutilized. There's 11 centers in the state, and I see some of my colleagues here. And so it's affordable, it's engaging to people, it gives caregivers time. They don't have to navigate the doctor's appointment. They don't have to navigate something on their phone when they've got someone putting their underwear in the freezer at home. You know, they really, it meets them where they need relief. So I just put that out there, that all adult days provide that level of support, as well as actual support for the caregivers, aside from attention and love and devotion to the person living with dementia. Our center we're all unique, so our center is doing a couple of things additionally. One is we've started doing a loneliness assessment based on the UCLA questions, and we're finding a real significant difference, statistically significant difference in the loneliness of the participants. Yeah, wow, there we go. 2 points for me. So people are less lonely coming to our center. We're also doing substance use screening to see if there's a connection between a way that we can help mitigate substance use with the people we serve, as well as the caregivers. And then we're situated in Addison County. There's no adult day in Rutland, as you're very aware, which is a tragedy. And we are not a senior center. You know, we're like a senior center on steroids maybe, because we provide that additional level of care. And then there's a very small adult day program in Burlington, which you can imagine would not meet the needs with 22 spots available. And so we are providing some transportation from Burlington, and we just got a grant from VTrans to enhance that program in Burlington and also provide transportation from Rutland. So my staff are like, really? We're going to find drivers to do this? But yes, we are. And talk to the communities about the fact that we can provide those services. So that's another innovation. And actually, another innovation we have, I'm looking right at Lexi, who's one of my staff. We're going to be implementing a gardening and composting program to provide that level of hands-on engagement. So our therapeutic activities program is alive and well. And if you want to talk to Lexi more about that, you want to just raise your hand up there. So composting, who knew? Okay, I'll pass it along.
So Christina, my question for you is, what would help the Memory Center advance cross-collaborative care across the state?
I think that's definitely something we have been working towards. We have implemented some programs for enhanced referrals to provide consultations with primary care providers who are doing the diagnosis and maybe need a little bit of more guidance in terms of getting a more accurate diagnosis, or if there are symptoms that aren't responding to traditional treatments. Being able to provide recommendations for better diagnosis, more accurate diagnosis and treatment for individuals. And then there was also an attempt in the past for one of our neurologists to actually have a designated, I think it was a half day a week, where he just had open office hours, essentially. So anybody could, any provider in the community who wanted to consult had the opportunity to do it. These have been poorly utilized. We're not getting very many enhanced referrals, and we stopped doing the half day a week because the neurologist was hardly getting anybody. Yeah. I have worked as a nurse practitioner in 2 states, and I don't think that this is a problem that is exclusive to Vermont, but we are getting much more into a refer mode. And I say this with a lot of empathy and compassion, because I did start my career in geriatric internal medicine as a primary care provider before going into specialty. And I certainly understand the demands that primary care providers are under. And giving them one more thing that is very, very time consuming when their system isn't set up in place to be able to meet the demands. Really do a thorough history and physical for folks who present with memory concerns. But we do need to be better about screening in the community and helping to release the pressure valve on the memory program, I think, so that we can start to develop some additional programs, because there is, it's myself, another nurse practitioner, and 2 neurologists in terms of, diagnosis and management. And one of those neurologists is approaching retirement. And so I think that if we can get our heads above water, then that would be a good first step. But also, I'm working hopefully with the VADC, the Vermont Alzheimer's and Dementia Care Program, to really help promote some of the tools that we have established, such as the enhanced referrals, making sure that providers around the state are aware that, yes, you can go ahead, start the screening, start the workup, get the diagnosis, use this if you are needing more assistance. We've also created a dot phrase that I'll talk about later this afternoon that is within the EPIC. Anybody who's using EPIC, we can give permission to use this dot phrase, which was created to help PCPs better diagnose. Basically, it's dot dementia DX, and it populates a set of questions diagnostic workup recommendations, connection service recommendations. This was created, I think, 2 or 3 years ago, never used. So we are working, hopefully, through the BOLD grant and the VADC program, I will be working to better promote some of these services and see if we can actually get people using them, get some feedback on how to better tailor them, and that's, I think, a place to start.
Yeah. Before we go on, although you can give Brendan the microphone, because I was going to ask, we have 2 primary care providers here, Dr. Orlin, geriatrician, and Brendan. Is what Christina's talking about, is that helpful? Is this sounding like something you could utilize, or barriers to utilizing it, or?
I mean, I think definitely, it sounds very helpful. I think my practice in particular is a little bit unique because I'm mostly getting people referred to me once they already have a diagnosis, and it tends to be more moderate and late stage dementia that I'm taking on, and so I'm more kind of helping families with that portion of the journey. So you might be able to speak more towards kind of the diagnostic component and how that would be helpful for your practice.
That's what we're trying to do by setting up an assessment program, is to get
Yeah.
people in, get them early, get them referred if they need to, or even start getting them access to treatment if we can.
Yeah, yeah.
Thank you. Okay, Brendan, now you get an actual question. What policy or reimbursement changes would make in-home dementia care more sustainable?
I think reimbursement is the biggest component there. You know, you have to factor in the fact that we are a rural state, so you are traveling. There is a lot of car time in between each visit. And as much as I try to manage my schedule where I'm not driving from, Ripon into Burlington in one day and then back down to Virgins, it happens because all of a sudden you have an acute visit and you gotta rework your day. And when you're spending that much time in the car, it's not reimbursable. And, try to make phone calls in the car, et cetera. But, there has to be, factoring in a way to either consolidate the radius of in-home providers or look at, some telehealth, although that's good for certain fragments or certain things that come up, but there is so much to be gained from seeing people in person and seeing them in the home and seeing what's really happening there, because on the phone and in that screen, things look great. And then you get to the home and you see the stacks of bills and you see that there's no food in the fridge and you can see the reality of what's happening. So, Medicare reimbursing for a 15-minute visit, for, 45 minutes round trip in the car and an hour plus seeing that person going through everything, hearing about their cat, talking to their daughter who lives in California. It's just, there's a lot of components to it. And inherently when you're doing, in-home, even if it's primary care, you're playing multiple hats. You're wearing the social worker hat. You're going to connect them with resources kind of in the moment. You don't have a team sitting outside where you can be like, hey, medical assistant, come in here and do this EKG for me. Hey, social worker, come in here and talk to them about resources. It's kind of all one person, which is fine. But again, then if you're trying to reimburse one provider for all of those roles, reimbursement has to look very different for that.
Thank you.
Mm-hmm.
Okay, next question. I had to change it after seeing your presentation. So GUIDE, as you know, it's a demonstration. It's a pilot demonstration model. Do you, with BrainLove, have a plan to work with ACOs or insurers to get them to carve out and pay for a model? And this, Brendan, it could even potentially apply to what you're doing to get insurances to pay for it, for what you're doing.
At the moment, I'm not doing that. It's not possible to both do what I'm doing and connect directly with Medicare Guide providers. I can recommend guide programs to my patients that they can then seek out. And in full disclosure, having now lived in the world long enough to see that you can research something for 15 years and show positive studies over and over again, and Medicare may pay for it a measly amount, and yet so many other things that are in pop culture do get paid for by payers that don't have any data. I'm going with the seeing real people have positive effects, and then studying this in ways I can, getting local funding and larger funding too as time's going by. So that's my answer to that, I guess. Yeah.
And then Mark, as one of 5 AAAs in the state, please describe how you partner with other organizations to provide dementia-capable care for rural residents.
Sure. So first of all, again, I spoke earlier about the Older Americans Act and how that guides a lot of what agencies on aging do. And you can think of agencies on aging as providing services like case management and our helpline. But one of the primary principles or tenets of the Older Americans Act is that agencies on aging function as hubs of networking and building out supports within a community. And personally, for me, that's one of the most exciting aspects of what I do, is to work with a lot of organizations, a lot of, we actually are fortunate, we have 3 adult day centers in our service area. So I get to work with them. We have senior centers, meal sites. So I do a lot of work just out in the community with hospitals and a variety of organizations, talking about what we do, talking about the needs of older Vermonters with cognitive decline or not. And so again, personally for me, that's something I really love doing. And if you look at my calendar, it's just full of meetings all over the place. But making those connections and really, I guess it's maybe I blame my father, who was a minister, that I think of this as my ministry, that I'm out really preaching sorry to get religious, preaching the gospel of aging in Vermont and supporting aging individuals and their caregivers. So that's just me personally, and again, part of what's baked into agencies on aging. I want to tell you that we have a terrific relationship with Dartmouth Hitchcock and Dartmouth College and the Dartmouth Aging Resource Center. And I'll make a shameless promotion here that the keynote speaker for my annual meeting next month is Dr. Serena Chow, and she's a nationally respected geriatrician and medical educator dedicated to improving the health and well-being of older adults. And she recently was appointed as the inaugural Chief of Geriatric Medicine at Dartmouth Hitchcock. So I'm really excited to, again, through my connections, to have this geriatrician come and be our keynote speaker. And actually, to just take this a step further, the topic that she's talking about is reducing ER visits in house calls patients with dementia. So she's talking about working with folks with dementia and doing house calls as a way to reduce ER visits. So that's one of the really exciting collaborations that I have. And again, also not just Dartmouth Hitchcock, but the Geisel School of Medicine. I have a board member who's a researcher with the school with Geisel School of Medicine. And we have a partnership with Dartmouth College in which professors will pick up a project and come and work with an agency. So we've had a couple of instances where college students come and work with folks in the adult day centers, work with folks in our memory cafes. A couple of years ago, we had, probably can't see this, but a team of 4 college seniors do art projects and build a collage with folks at our memory cafes. The other exciting collaboration I'll just say that we have is we have gotten grants from the Vermont Council on the Arts. And last year, with that grant, we bought sewing machines and we took them to the middle school in Springfield, and a group of middle schoolers sewed lap quilts out of various materials. So these were tactile, stimulating materials. So they spent the semester sewing these lap quilts, and then they came to our memory cafe and presented the lap quilts to the participants. It's going to make me choke up because it was so touching. And again, so it's so exciting because this is intergenerational. We're exposing these college students to folks with cognitive decline and their caregivers. We're exposing middle schoolers to folks with cognitive decline and their caregivers. To me, that's so important. Having just again worked in social services most of my career, it's so important that we let other people outside of our little bubble of profession know what we do, know the challenges and hardships that people encounter who are experiencing this. And so that's, again, for me, part of what I do in my ministry is get that word out there. We have so many, I have a long list here of collaborations that people we collaborate with. There's a hospice center in Brattleboro that we've done some work with. We work with the music center in Lebanon to bring a music therapist into our memory cafes. So that's a tremendously exciting collaboration that we have. I work with all the hospitals. There are 5 hospitals in my catchment area. I work with them and how to support folks with dementia who are coming into their hospitals. All sorts of, yeah. So lots of collaboration. I'm out there doing that every day.
Thank you. And will you be here for lunch if people want to look at your list?
I'm here all day.
Okay, awesome. So who is anybody here from the Upper Valley area? So it's okay. So you guys stole Serena Chow. She was at Cambridge Health Alliance, and I worked with her very closely on her house calls program, in which nurse practitioners went into the homes of frail elders within Greater Boston, typically underserved areas in Greater Boston. And she's amazing. So I'm so glad she's working with you. I miss her dearly in the Metro Boston area. Glad she went to Dartmouth and didn't completely desert me, like going to Arizona or something. But yeah, so that's terrific. I think we still have 15 minutes. So does anybody have questions for our panelists? Oh, lots of questions. Okay.
This is a. Oh yeah. Oh, I love the microphone. No. I mean, not that you want to hear. Thank you. This has been very interesting. My name is Helen Laban. I run the Vermont Healthcare Association, which represents residential long-term care providers. Forgive me for what is a very brass tacks question here. One thing that we look at is what is the capacity, especially in our rural nursing homes, to serve the increasing population of those with advanced dementia. It's not good, just FYI. It's not great. We do what we can. We're going to keep working on expanding that and providing high quality care. One thing that I wonder when I look at timelines such as what was presented this morning in terms of new treatment innovations and new prevention innovations is, how long do we wait for a downstream effect on reducing some of that pressure on the capacity at the very furthest end of care and intensive care? Because like I said, we're going to continue to work on it, but rural America really needs some reduction in that pressure on a very limited capacity.
Was that just one specific?
That was, anyone who wants to speculate on that, I would love to hear the answer.
Anybody have thoughts?
I can take a stab at it. So I think if I understand the question correctly, it is what can we be doing better to help alleviate some of the stress from the like nursing
Oh, no, I
homes?
assume you're going to alleviate it. How long do we have to wait?
Oh, that all depends on how things go in terms of funding. So when I'm working with these dyads in through the UCLA model, some of the biggest barriers that I found were folks are not only waiting too long to get diagnosed, they're also waiting too long to get access to treatment and resources. And one of the biggest problems I think that I experienced, I guess the frustration that I experienced is that by the time these dyads were referred to me, the patients and the care partners were so far underwater that it did not matter the number of resources, the number of recommendations, anything that I had in mind that might be able to help them. They were so stressed and really just trying to get like one little grasp of air every now and then that just the simplest thing was too much for them. And so I think that it really does start earlier on, and we need funding for, these people need support, not necessarily, medically speaking, but they need help in the home. They need someone that they can turn to when the person that they're helping care for is starting to experience these behaviors, so that they can learn ways, non-pharmacological ways to provide interventions at home so that they're not contributing more to the stress that leads to eventual placement. We can keep these folks at home with earlier interventions, better support. I don't have a timeline because that's not my job, but I hope that it's coming, and I hope it's coming soon. But I think we're going to have to see how things continue to go in terms of funding and the grant world, and yeah.
Yeah, I'll just, go ahead. Okay. Just, I don't have anything about timeline here, but just a thought is that, I feel like it is so important for us to continue to really focus on supporting those with moderate to late stage dementia, because I don't anticipate that things are going to change really quickly. And I worry that with so much of the conversation and so much excitement around treatments and new medications and all of this, that some of the attention and focus is going to get diverted away from all of these individuals that are still really struggling and are going to be struggling for the foreseeable future. And I think we still need to make sure that we're investing time and resources as a state to support those folks. So,
I would just add that the new treatments that, say, the Alzheimer's prevention treatment that will get approved at the end of next year, probably will slow things down by about 5 years. So either delay the onset of symptoms by 5 years or keep you in the same stage, like keep you in MCI for 5 years. So that really can make a huge impact on the number of people that are progressing to severe cognitive impairment. And so, but you're not going to see that for 15 years. But I think that things will change dramatically with this treatment getting approved, because a lot of people will want to look into that, and there's hope and there's something you can do. And I think this is why I try to use different words and forget everything you knew about dementia and Alzheimer's, because we're in a totally different world now, but that requires these really amazing high touch things. So I do think there will be a sea change, but there's a lot that goes into long-term care, and there's a lot of other factors that, yeah.
So, yeah, Kristen, but you got your timeline, 15 years.
Yeah, we'll check in.
Great.
I just want to echo what Christina was saying. The longer we can help people stay in their homes, the easier the burden is on the already overtaxed nursing homes. And so that's the way that Adult Days in particular can support people staying in community where they tend to have greater support systems. So we have to support the caregivers and we have to keep our community structures alive. And, you know, we do a lot of things so people know who we are. We have volunteers in the community. They come in and they think, oh, this is a pretty nice place. I wonder if my mom would consider coming. And maybe it takes a couple of years. So I think there's just, if we can reduce the burden of the nursing home just by creating those community supports, we'll be really ahead of the game by the time the 10 or 15 years. Thank you.
I have a quick comment.
Oh,
I'll make it quick.
you just want to joke.
I don't have another joke. So one of the things that we're going to try to do as well is a very aggressive de-prescribing program. So what's happening is with the polypharmacy, and not including just prescription medication, but everything else that you can get in your hand and down your gullet in a day with your prescription medicines means they ain't working. And you're probably on so many of them because they're not working because you're on everything else. So long story short, especially in the nursing homes, when you come in and you were on a med list before you got there, a med list while you were in the hospital, and then a med list that they think you should be on, but they're not taking care of you anymore, we have a huge opportunity.
Yeah.
That's my biochemical pharmacology.
And I see you.
My question's for the two PCPs in the room particularly. I have a lot of caregivers that come to me and they have completely neglected their own health because they're taking care of someone with dementia. So in my mind, when you have a patient that comes to you with dementia, you now have two patients. What are you doing to help the caregivers recognize that they're a caregiver and to make sure that their health needs don't slip through the cracks when
So
you're
the
patient?
first question is, how can I help the patient? The second one is, how can I help the caregiver?
Both are about the caregiver.
Right, no, but that's what happens when you walk in the door, right? It's not only how do we help that person that's the sufferer, how do we help the person that's suffering? And you ask them, how can we help you? What do you need? What can we put you in front of? Who can we get you to help you? So it's a recognition, half the battle is that there's more than one person that has a problem, and that's just the basics of what we do. Otherwise, we're not accomplishing anything.
I always start by just saying, you know, especially if it's a new patient, you know, I'm now part of your care team and we're all working together on this. And so, you know, I'm not going to say this is what you have to do or this is what you don't do or whatever. You know, we're working all together. And I find that care partners, you know, they just feel a lot of relief when they really feel like somebody's in their corner and that they have somebody that now they can call. When they have a question, they don't understand something, something's not going well, if they know that they have somebody reliably that they can turn to, I think that they get a lot of benefit from that. And then also, you know, making sure to refer them to appropriate services, you know, for additional support. Dementia Family Care Center is great, you know, just all of the additional networks, you know, to kind of get them looped in there is crucial as well.
Yeah, I'm going to come over to Orlando and then I'll go back to Megan. But the Alzheimer's Association has a ECHO program for primary care practices, and I've been able to sit in on some of them, and it's really interesting that the issues that come up are often with the management of the family caregiver. The person with the disease is stable, right? We've got them going on. We do prescribed all the medications. We did all the right, made sure they were safe, all that. Got them into adult day health, all these other wonderful things. And then it's the family caregiver who's kind of the train wreck in the dyad. So thank you for the question.
Can I just add that a lot of them don't know the statistic about care partners die before the patient.
Yeah.
And so just saying that, and if you want to be the best caregiver ever, which you already are, and you want to keep doing that, you need to stay healthy. And so they do it for the other person still, but at least they take care of themselves.
Great
Sorry.
point, great point.
So as a case manager, I find some of my frustration is people, the caregivers not understanding the disease, number one. So that whole piece of argument, mom, you don't have kids, right? To get them to understand that's not beneficial is tough. Lack of in-home caregivers as far as people coming in on the children's care, if we don't have the lack of a neurologist, all of that. How as a case manager going in, how would you recommend we best support those families? Immediately, I'm thinking because we're in Winter County, I'm just going to switch them all over to PCPs in Rutland.
I'm trying to retire.
Who wants to answer that? Christina does.
Got lots to say. So I wanted to share the resource that is also involved in this next year's iteration of the BOLD grant, the Dementia Family Caregiver Center through UVM and UVMMC. It is a service that is run by licensed clinical social workers who are designed they are trained in memory care, and their main focus is not only caregiver support, but also caregiver education. This is another resource that we offer that is poorly utilized. They offer 2 classes that are designed for caregivers. One is the TEACH program, which is designed for new caregivers, somebody who maybe just received a diagnosis. This is earlier education. And then we also have the Carers program, which both of these are evidence-based tested programs designed for interventions for education for caregivers. The Carers program is much more tailored towards those who are maybe in the moderate to severe stages and experiencing some of the behavioral and mood symptoms. But not just, even outside of the structured programs, they offer caregiver support services, connection with other caregivers. That is where a lot of the folks that I work with get recommendations. Have you tried this? Oh, my husband does that too. This really worked for us. Have you thought about this? And so really connecting the caregivers with education, support, and resources, whether that's through something that's more structured or if it's through case management social workers. We have also social workers within the memory program who you do have to have a diagnosis of dementia in order for them to see, but the DFCC can start seeing people all over the state. They're remote, they don't have an actual physical building, and so they can pick up the phone and say, hey, tell me a little bit about what's going on and let's find some ways to support you. So there are resources, but I think that this kind of circles back to when I talk about connection, I feel like there's a lot of fragmentation in care, and even individuals like myself who specialize in this, I'm not even fully aware of some of the resources that are going on in the state. And so I think that we need to find ways to better connect people so that we can also connect these caregivers, that the people who are really struggling at home. We need to know everything that's available to us so that we can pass it along to them.
Can I just chime in? I just want to say that we have a similar program in Addison County, the Center for Positive Aging. It doesn't have the structured therapeutic groups that you have, but it has caregiver support over Zoom once a month, and we have another caregiver check-in group as well. We have very affordable counseling program with expertise in aging and dementia care through our team of social workers. $65 an hour private pay or Medicare, government Medicare. So the intent is to really support those caregivers, and I would encourage us to think beyond diet to family systems. How often is it just, there's mom, but the kids think something different? There's often stepchildren involved. There may be former spouses involved. There's nothing predictable about the family who comes to you and needs help.
Yeah, so 2 points. In southeast Vermont, the towns all have CARES groups, right? Not-for-profit, volunteer, supporting the community in any issue they have, mostly medical support and other things. They're retired nurses, they're people that just care. So it takes a village, you've heard it before, really means it when it comes to being able to accomplish a lot of this stuff. I had another thought, but I'm all.
What'd you have for dinner last night?
Is there a referral process on that, or?
I'm sorry.
Yeah, so it depends on the town, like Westminster Cares, Putney Cares, I know, Bellows Falls has a senior center. All of these little towns have a touch point, right? And they have programs, they have activities, but they help each other. It's wonderful. And it just, it's everybody, oh, that's what I wanted to say, thank you. So years ago in geriatrics, we had what was called the NICA project, right? And we found out that everybody, including nurses, think that they know more about how taking care of older people in the hospital and when it comes to dementia than they really do. But what did that really tell us? It told us that everybody that came in contact with that patient, no matter where they were in that hospital stay, could have an opportunity to be trained more to be geriatric centric. Well, it says the same thing for dementia. So that everybody who has a touch point, if they're given a little bit of training, how do you keep someone from joking Heimlich? How do you do CPR? This is where we need to go if we're going to do this, because there isn't enough money in the system for everybody to get it. My personal opinion, keep politics out of it.
I see you. There's Megan's turn. Oh.
I want to be mindful of time, though.
How are we
It's
doing?
okay, it's okay.
It's okay?
This is important to get the questions, so
Okay.
please.
So I guess this is a long drawn out. I'm looking at this from an overall, right? So I'm hearing a lot of dedication, a lot of passion within this room. And we're all very privileged to be here and sit here. I'm hearing we need to destigmatize, we need early intervention, we need grief support. And how are we going to get this traction to get it covered under a medical model through insurance? Yeah, we all know what that goes. How are we bringing this conversation to our smaller, more rural communities? Because I'm sitting here and I'm representing a small rural community. I'm representing a AAA, I'm representing a first-hand caregiver. And I want this conversation where I'm at, in my community. And how can we bring that to our smaller communities and our town meetings, or if that's even, excuse me, I don't know if that's a thing, but or something of that nature, and not just in a room where we're all collectively, we want to do this, we want traction, we want this, we want to move forward. So I don't know if this is, I'm not framing that well, but.
I'm going to take this one and then I'll pass it to you.
That's good.
So I have some colleagues here in the room with me who work for the Vermont chapter of the Alzheimer's Association. Joe Cotto, Meg Pleat, Howard Goodbrow, our chief cook and bottle washer, Jasmine was here. I don't see her anymore, but anyway, they are
right here.
Oh, there's Jasmine. She didn't go anywhere. That's good. I was watching. But any of them can partner with you in your community and work with you, offering programs, support groups, helping you to set those things up. Okay, so you guys talk to Megan. And then,
Can I just make a comment?
Sorry.
In tandem with the Alzheimer's Association, is the opportunity for doing a local conversation, right? And there's fantastic educational opportunities through the Alzheimer's Association. And we're also interested in having those local conversations. So we've done several pairings where we do education followed by discussion. What does it look like in your community? What do you need? What's available? What's not? Many of these things are right in 3, 5-year, 10-year time spans. And so as a collaborative, we're very interested in doing that. We don't always have the time to do it, but don't hesitate to reach out to the health department, to the Alzheimer's Association, and we'll see if we can, help with that.
Thanks. We are coming up on time, so I know that Rachel, who is a rock star, because she got called out in the keynote, so I'm going to let her.
I more had a comment/nerd out to somebody's question up front, and would love the panelist thoughts as well, about like when we have a caregiver who is struggling with something we're educating them on and they're having trouble like processing that information. There's a model that's actually based in smoking cessation called the trans-theoretical model about like a person's readiness or willingness to change their behavior.
And in Skills to Care, we take that model and apply it to caregivers to really understand, like, where are they in this staging of their willingness or readiness to change behavior, to accept the diagnosis. And then I think that being able to kind of stage caregivers in that way can be critically important to us as providers, because we can tailor our education to meet them where they're at. So if we have a caregiver who's like lower readiness, for example, Dementia 101 is where we're going to meet them, versus a caregiver who's really high readiness. We can like start with strategy development and really brainstorming, what are possible solutions. But that's not an approach that's going to work for every person at every stage. So thoughts from the panel.
She just wrote a thesis, I think.
I think it's what you're saying. It's really important to not just what we're giving caregivers, but really how we're doing it. And so I would just say they're spinning, so it's up to us to be calm and identify is there immediate, imminent safety issues. Usually there's not, but there's a lot going on. But that doesn't mean it's going to take 100 steps to fix it. And if we can hold space and calmness and help them find the first step forward, acknowledging that that step might not be the winner. Maybe support groups aren't for you. Maybe you need a different kind of engagement. It's like one small step at a time, but you're like forging this bond with them and you're like, we're doing it together. And if it doesn't work, I'm here. So it can feel like, right, insurmountable when someone's like, and I just had a family member email me like, a scroll and then another scroll email. I was like, oh my goodness. So, but then we had a good outcome during the visit after I took that time to do that. But it's not easy, so I just want to say that.
It's so stressful to be a caregiver, so they can't hear necessarily your wonderful advice, your 20 years of wisdom. I love your model, Rachel. I'd love to talk with you more about it. I'm just realizing that sometimes just what people need is to be heard, and then they can take the next step into what they can do. And that as much as we know, we don't know what's right for them and what they actually can manage. And they've loved this person for however many years, or maybe it's reigniting some trauma for them that their mother's behaving this way. We don't know the depth of that. What can we offer them? We can just offer acceptance and help them get to a place where they can do whatever makes sense for the next step is for them.
Rhonda, would you like to wrap us up?
Oh, wow.
Okay,
so
Or you can
first,
go there.
yeah, no, that's true. Can we thank this?
Podium, please, so they can hear you.
What's? I'm sorry. Is this better?
Could you step
Just
to the
what-
podium?
Okay. Can we thank these panelists for such a wonderful. Amazing array of experience and expertise, and I feel like such a sense of modesty as well, right? Because it's complex, it's personalized, I was just thinking, in listening to this, like if we were to develop, if we had time, wouldn't it be fun to do a word and phrase cloud, like of all of us, and what, words and phrases resonate with you today, whether it's in work that you're already doing, whether it's in what you would like to do. And some of those that appeared in my head, I was hearing, we have some, I'm phrasing, quick changes. We have advancements in science and in care, and I think acknowledgement of not only the complexity, but also that this is truly team-based. Whether it's in the home, in a clinic, at the state level, at a regional level, and kind of stemming from that is that this event today could not be done without a team. And we have a really strong work group, and the slide that you perhaps noticed when you walked in, those are just some of the partners that help make today possible. But also area agencies on aging, adult day centers, those congregate meal sites, we have 40 of them. We have 40 senior centers in the state of Vermont who try to make it happen, and they don't receive state funding. So there's a lot of pieces of care, and that's what we're aiming to do, is to pull together what we do have as a state from I think the lifespan of both preventing the disease, delaying the disease, and diagnosing and caring for the disease. So we are looking at all those elements. So there's just a few things I wanted to mention in that. So we meet monthly as a work group. Anyone is welcome. You could be a care manager, you could be a caregiver, you could be both of those things. You could be clinical director, PCP. We welcome all to have this conversation on a regular basis. We started meeting, I don't know, 2017, and we've been continuing to meet every month. So first Thursday of the month at 9 a.m., you're all welcome. Just reach out to myself or Tiffany in the back or Ed, and we will put you on the list. Another thing is, as I mentioned before, is that we want your comments, your feedback. You will receive, I think, a survey following this, and you can give us feedback then too. But if you want to do it today, feel free to. We also have, and please stay for 3 sessions this afternoon. These are people who are donating their time to provide their expertise and build, right, the cognitive functional impairment capability of our state. So one of them in the Linden Room is on building dementia-capable emergency responders, right? So important as we try to create the glue in our local communities, and first responders are so important, so critical in so many ways. So that is in the Linden Room, and we'll provide direction too. If you are here and wanting to attend the current landscape of dementia screening and diagnosis, you're going to be in the Red Oak Room. One of the things I want to mention about this one is annual wellness visits. So at the health department with partners, we are promoting the annual wellness visit. Nurse-led annual wellness visits, it's evidence-based, it's reimbursable. It helps to provide a routine care and I think also in a way of cognitive screening as part of our aging. And I think we can destigmatize it through annual wellness visits. So we've been promoting it. We look forward to your joining that, which will also be joined by Christina, right? You're in that. Christina is fabulous. She is our first dementia specialist in Vermont. We are hoping to get more dementia specialists. Yes, using the UCLA dementia care model, but tailoring it to Vermont at the same time. So if you want to learn more about that, go to the Red Oak Room. And then our third one is around dementia-related behaviors. We are very fortunate to have Rachel Wiley, Dementia Collaborative. She's part of our work group. Dementia-related behaviors, so there's prevention strategies to those. And so Cherry Room will be your room for that. This room, Rachel. We're going to take a photo of our panel, so do not move, okay? And also, I think that, Dr. Cabral, I cannot thank you enough for coming to Vermont. When I reached out to you, I thought, there's no way. And wow, you said yes. You're here. I think that it's such a powerful message, and I was the one, I admit. I was like, what? High touch, high tech? You know, we're a rural state. We have so many, challenges. And what you're doing from a researcher and from a provider, I think it's amazing and it's inspiring. And I think we will be able to take elements of what you do and find ways to do it in Vermont that helps give people, even who are maybe genetically disposed, to have hope and also to have specific actions that they can take. And that's what we're seeking to do in our work. So thank you so much, and thank you everyone for being here.